When you watch those magnificent equine athletes thunder down the track or soar over a jump, what hidden challenges could be quietly undermining their incredible performance, potentially leading to, well, devastating consequences? Today, we're taking a deep dive into equine stress fractures, a persistent and frankly complex orthopedic issue that sidelines too many of these extraordinary animals. Our mission for this deep dive is to break down everything you need to know about stress fractures, what they actually are, how you might spot them, the cutting edge ways vets diagnose them, the best treatment strategies, and most importantly, how to prevent them in the first place. Ensuring these amazing animals have long, healthy careers. We've distilled the most important insights from comprehensive veterinary research and expert opinions specifically for you. So let's start with the basics. What exactly is a stress fracture? It's basically an incomplete break in otherwise normal bone, kind of like bending a paperclip back and forth repeatedly. Each bend on its own doesn't break it, but eventually the metal just fatigues and cracks. Here, it's from the repetitive application of mechanical loads that target the dense outer shell of the bone, what we call the cortical bone. You might also hear it called a fatigue fracture. The terms are pretty much used interchangeably.
Yeah, and what's really critical to understanding these injuries is the constant sort of hidden race happening inside the bone itself. Bone is an incredibly dynamic tissue. It's always tearing itself down and rebuilding. We call this modeling. Adding or removing bone to adapt to different loads, and remodeling, which is its continuous renewal process. And this whole process is driven by two main types of cells: osteoblasts, which are the builders, they deposit new bone, and osteoclasts, which resorb or kind of clear away old or damaged bone.
Right, the cleanup crew and the construction crew.
Exactly.
And here's where the real vulnerability comes in, right? There's this crucial point in the repair cycle, what's called the lag phase. So when a horse undergoes repetitive mechanical loading, like in athletic training, it induces microscopic damage to the bone. And in response, those osteoclasts, the cleanup crew, they rapidly move in to remove this damaged bone. That process starts really fast, within like 48 to 72 hours, and it keeps going for maybe 2 to 3 weeks. But the catch is, new bone formation by the osteoblasts, the builders, is much, much slower. It often takes over 3 months for a complete replacement.
Precisely. So you have this period where damaged bone is actively being removed, but new, stronger bone isn't fully in place yet. If that repetitive stress continues during this vulnerable lag phase, well, the microdamage just accumulates faster than the body can repair it. This reduces the bone's stiffness and strength, creating this self-perpetuating cycle that ultimately leads to a stress fracture. It really highlights a critical challenge, finding that delicate balance between pushing an equine athlete to strengthen its bones and, respecting its temporary vulnerability. It truly underscores the need for meticulously managed training progression and, importantly, recovery periods.
And that gets right to the heart of why these injuries happen, doesn't it? Beyond the basic bone biology, what are the primary risk factors we need to be aware of?
Well, the main culprit's pretty clear. First, just repetitive, strenuous exercise. It's inherent in disciplines like racing. It's simply part of the job. Second, a sudden increased intensity or frequency of training, especially in young horses, can just overwhelm the bone's ability to adapt. Like, for example, dramatically increasing canter exercise in a previously untrained horse's bone. That significantly raises the fracture risk.
Okay, but here's a dilemma that truly complicates things, one that might surprise you. Sometimes too much rest can actually be just as risky as overtraining. Let's talk about layoffs and return to training. So prolonged rest, especially if it's longer than a month, can cause disuse osteoporosis, basically. The bone weakens from lack of stimulation. This makes it incredibly susceptible to injury when a horse suddenly resumes intense exercise. So while rest is obviously needed for recovery, a carefully managed reintroduction to work is absolutely critical. It's a real balancing act.
It really is. And training and racing surfaces also play a significant role. The characteristics of the ground, the footing, directly influence how forces are transmitted up the limb. And consequently, that affects the incidence of distal limb fractures. For instance, some studies link sand gallops to an increased risk of fatal distal limb fractures in the UK. And dirt racing in North America has historically seen higher injury rates, including fractures, compared to, say, turf tracks. It really highlights that intricate interaction between the ground beneath them and their biomechanics.
That's fascinating. And what about age and sex? Does that play a role?
It does seem to. While stress fractures can pop up in foals as young as 3 months, they're most commonly seen in that 2 to 4-year-old age group. Interestingly, some research suggests that training and racing as 2-year-olds might actually reduce long-term fracture risk, maybe by stimulating early bone adaptation. It's a bit counterintuitive. And fillies, for their part, may have a slightly higher risk of pelvic fracture specifically.
Okay. And one more factor?
Right, finally, we need to consider bone demineralization. Horses on strict stall rest or with very limited turnout are prone to this. Particularly young horses transitioning from extensive turnout where they're constantly moving and naturally building bone to minimal or no turnout during intensive training periods.
Okay, so we know what they are and why they happen. Now let's explore where these fractures typically occur. Are there specific anatomical hotspots for these injuries?
Oh, absolutely. These aren't random occurrences at all. Specific bones are consistently predisposed due to the unique, really intense biomechanical forces experienced by, particularly, racehorses. And understanding these locations is crucial because it directly guides our diagnostic efforts and helps us develop targeted preventative strategies. You know where to look.
Can you walk us through the most common sites? Where should people be thinking?
Sure. The third metacarpus, which most people know as the cannon bone, that's a classic site. Here we often see buck shins, which is basically a painful inflammation and microfracturing on the front of the cannon bone. It affects over half of 2-year-old racehorses. It's very common.
Wow, half. That's huge.
It is. Then there's the tibia, the shin bone in the hind leg. That's highly prevalent, accounting for maybe 40 to 60% of stress fractures, especially common in unraced 2-year-olds. The humerus, the big bone in the upper front leg, makes up maybe 6 to 27% of cases. It's a bit more common in 3-year-olds, typically affecting the neck area or the distal cortex, the lower part. Pelvic fractures, affecting the pelvis obviously, account for about 25% of all stress fractures, with the ilium, the wing, and chast being the most common part involved. And surprisingly, maybe vertebrae, particularly in the lower lumbar region of the back. One post-mortem study found evidence of these in 50% of the racehorses examined.
50%. That seems incredibly high. Were they causing obvious problems?
That's the tricky part. Often they present with vague signs, which we'll get into. And while much rarer, the radius, forearm bone, and scapular shoulder blade can also be affected, sometimes quite severely.
So knowing these specific locations isn't just academic. It's fundamental for vets and trainers to know exactly where to focus their attention when they suspect an issue, right? It helps narrow things down.
Exactly. It's about knowing where to look for the invisible foe, as you put it earlier.
And accurate, timely diagnosis is absolutely critical because if you miss a stress fracture, it can progress. It can become a more severe, potentially career-ending or even life-threatening complete fracture. So how do we even begin to recognize these often subtle injuries? What are the typical clinical signs and lameness characteristics?
Well, the first challenge is that the signs are often really varied and subtle. The lameness is typically intermittent and exercise-related, meaning it usually shows up during or after exercise, and it might come and go. One day fine, next day a bit off. Its severity can vary widely too, from moderate, maybe a grade 2 out of 5 lameness, to quite severe, like a grade 4, especially after high-intensity work. But often, it resolves pretty quickly with reduced intensity. Sometimes, it can even present as acute onset, a sudden severe lameness during training that then improves significantly within 24 hours. Which can be confusing.
Yeah, because you think, oh, maybe they just stepped wrong, and then they seem better.
Exactly. And here's where it gets really tricky for diagnosis. Upper limb stress fractures, like in the humerus or pelvis, can be unresponsive to routine limb flexion tests and even regional nerve blocks, making localization really difficult sometimes.
So if the signs are often so vague and intermittent, like maybe just a bunny hop gait you mentioned or poor movement, what's the very first thing an owner or trainer should do? How do they differentiate it from just a tired or maybe slightly grumpy horse?
That really is the million-dollar question, isn't it? And it's why a high index of suspicion is required in athletic horses, particularly the young ones in heavy training. Any change in performance, any change in attitude under saddle, or even a very subtle, fleeting lameness that just seems off it, should prompt a call to the vet. Don't just brush it off. You might also observe more subtle gait changes, like maybe a rough or slightly shortened gait, or just a general decrease in performance, especially if the fractures happen to be bilateral, affecting both sides.
And are there any classic site-specific signs we should look out for?
Yes, there are a few telltale signs sometimes. For tibial stress fractures, you might see that classic bunny hop gait where the horse seems to lift both hind limbs almost together. Pelvic and vertebral stress fractures often present with really vague signs like just poor movement, stiffness in the back or hindquarters, maybe a loss of impulsion or action, a shortened stride, or tracking off to one side consistently. They can even mimic tying up that severe muscle cramping syndrome.
Ah, okay, so that could be misleading.
Very. For humeral stress fractures, there might be an unwillingness to perform, a shortened cranial phase of the stride, meaning they don't reach forward as much, and often pain when you manipulate the elbow or shoulder joint. And buck shins, back to the cannon bone, usually cause obvious pain in the lower forelegs, often a hot swollen bump you can feel, favoring a leg, limping, and definitely decreased performance. That one's usually less subtle.
Right. But the vague, intermittent, or mimicking nature of many of these signs, coupled with the difficulty in localizing pain, especially in the upper limb, it poses a significant diagnostic challenge. It sounds incredibly frustrating for vets and owners, potentially leading to delays in getting the right treatment.
It absolutely can be, which is why after a thorough lameness exam, where maybe lower limb causes are ruled out with nerve blocks, advanced imaging is truly the next critical step. We need to go beyond what the eye can see or what can be easily felt.
Okay, let's dig into those advanced diagnostic imaging techniques. Let's start with radiography or x-rays. It's pretty standard, widely available. What are its strengths in this context?
Right, x-rays are often the first go-to. They're widely available, portable, and typically don't require anesthesia, which is a big plus. They can detect stress fractures in maybe about half of cases where a bone scan identifies a lesion. They might show an incomplete fracture line or perhaps dark spots, lucencies indicating weakened bone, or even new bone growth, a callus forming around the injury site. They're also very useful for monitoring how things are changing once a diagnosis is made, tracking healing.
But what are its critical limitations? Because it sounds like half the time it's just not enough.
Precisely. The main issue is sensitivity. It's simply not highly sensitive, especially early on, within the first 1 to 3 weeks of the injury developing. Initial radiographs for tibial or humeral fractures, for example, are rarely conclusive because the subtle bone changes haven't fully developed yet to be visible on an X-ray. Plus, imaging upper limb fractures is inherently challenging due to all the overlying muscle mass and the limited angles we can actually get with a portable machine. And another point, a visible callus on an X-ray doesn't always correlate with active pain. The bone might be healing, but the callus remains. So the crucial takeaway here is that a clear X-ray often isn't clear enough, unfortunately. Relying solely on it can be a recipe for disaster, potentially missing early fractures and risking a catastrophic break down the line. That's why we often need to combine different imaging techniques, use a multimodal approach.
Okay, so if x-rays often aren't enough, particularly early on, what's considered the gold standard for that early detection?
That would definitely be nuclear scintigraphy, commonly known as a bone scan. It is incredibly sensitive for early detection of active bone remodeling and stress fractures. It often identifies problems long before any X-ray changes would appear. How it works is we inject a small amount of a radioactive isotope, usually technetium-99 meters, which naturally binds to areas of active bone turnover where bone is being laid down or resorbed rapidly. A special gamma camera then detects the radiation, showing us hotspots areas where the bone is very metabolically active, typically due to injury or inflammation.
Right.
It's great because it can image large areas like the neck, back, pelvis, and limbs all in one go, making it invaluable for those subtle or mystery lameness cases where the location isn't obvious. And the procedure is typically performed standing, just under mild sedation.
Wait, that sounds incredibly useful. What are the drawbacks then? It sounds almost too good to be true for picking things up early.
Well, it's not portable, and it requires specialized facilities with radiation safety protocols, which definitely limits its accessibility and adds cost. It also offers poor anatomical resolution compared to something like a CT scan. You know where the activity is, but not necessarily the exact structure involved in fine detail. And a significant challenge diagnostically is that these hotspots can remain visible for several months, even after the bone has technically healed. This can really complicate decisions about returning the horse to work. Is the bone truly healed and stable, or is it just showing some residual remodeling activity? It's not always clear-cut.
Ah, okay. So it tells you something is happening, but maybe not exactly what or if it's fully resolved?
Exactly. However, despite these drawbacks, its role as a powerful screening tool is unparalleled. It helps us localize the problem area very effectively. Then that directs us to use higher resolution studies like CT or MRI on that specific spot for a definitive diagnosis and to really assess the clinical relevance of that hotspot.
Okay, that makes sense. How does ultrasonography, which we usually think of for soft tissues like tendons and ligaments, help detect bone issues?
Yeah, ultrasound can actually be quite useful for detecting and monitoring more superficial stress fractures and the callus formation around them. It's particularly good for certain locations, like caudoproximal humeral stress fractures, that's the back upper part of the humerus, and also for callus formation on the iliac wing in pelvic cases, which are relatively accessible to the probe. It's inexpensive, readily available, and usually doesn't require anesthesia.
So where is it limited then? Why not just use ultrasound everywhere?
Well, its utility is really limited to areas that are accessible to the transducer, so primarily superficial bones or specific deep areas where we can get a good acoustic window through the muscles. Also, a callus might not always be visible on ultrasound, even if it's there, and its absence certainly doesn't rule out a fracture. You can miss things. But for the specific anatomically accessible sites, ultrasound offers a less invasive, more immediate, and often more cost-effective diagnostic and monitoring alternative compared to, say, repeated bone scans.
Got it. What about computed tomography or CT? How does that stack up, especially compared to an X-ray or a bone scan?
CT provides incredibly detailed cross-sectional 3D images of bone. It effectively eliminates that problem of superimposition you get with a flat 2D X-ray where bones overlap. It's crucial for diagnosing and, importantly, planning the repair of complex fractures, and also for evaluating very fine microfractures that other methods might miss. And a big advance recently has been the development of standing CT systems. These reduce the need for general anesthesia, which always carries risks for areas like the head, neck, stifle, and the distal limbs.
That's a huge plus, avoiding anesthesia. Any downsides to this high-tech option?
Well, CT scanners are definitely not portable. They're big hospital-based units, and historically imaging most body parts required general anesthesia. There's also radiation exposure to consider, and it's generally more costly than X-rays or ultrasound. But its unmatched anatomical precision is invaluable for complex cases, for surgical planning, or when precise localization is absolutely critical. It's often used as a confirmatory tool after a screening test, like scintigraphy has pointed to a problem area.
Right, getting that super fine detail. And finally, magnetic resonance imaging, MRI, often called the soft tissue king, right? How does it perform for these bone issues?
MRI is indeed highly sensitive for subtle bone changes like bone bruising or edema, and yes, it excels at visualizing the soft tissue structures around the bone ligaments, joint capsules, cartilage. It's considered ideal for detecting early stress remodeling or stress fractures, sometimes even before X-ray changes become apparent. In human medicine, it's often considered more sensitive than even scintigraphy for detecting early cortical stress fractures. A key advantage in horses is its ability to visualize soft tissues and structures within the hoof capsule, which other modalities struggle with. And importantly, it's a very safe procedure, no ionizing radiation.
So what are its limitations for horses? Sounds great for tricky cases.
The main limitations are practicality and cost. It's not portable, and it often requires general anesthesia, as standing MRI options are still somewhat limited in availability and the areas they can scan effectively. Scan times are typically prolonged, often an hour or more, and it's generally the most expensive imaging option. Also, imaging the equine upper limb, like the shoulder or hip, with MRI isn't always feasible due to the sheer size of the horse and the equipment bore. But MRI's superior sensitivity, especially for bone edema and soft tissue, makes it invaluable for subtle or complex lameness cases where other modalities are inconclusive, or where soft tissue involvement is suspected alongside a bone injury. It's often a tertiary, highly specific diagnostic step when you really need the most detailed picture.
Okay, that's a great overview of the diagnostic toolkit. So once a stress fracture is definitively diagnosed, what's the road to recovery, treatment strategies? Sounds like it's definitely a multifaceted approach, not just one thing. Let's start with the foundation. Conservative management, rest and supportive care. What's the thinking there?
Yeah, this is truly the cornerstone of treatment for most stress fractures. The vast majority, thankfully, heal without major complications when that excessive mechanical stress is removed or significantly reduced. For acute or severe cases, strict stall rest is typically initiated right away until the horse is comfortable at a walk and no longer acutely lame.
Okay, but I've heard before, and you mentioned disuse osteoporosis earlier, complete confinement isn't always ideal long-term, is it? Can you unpack that a bit?
That's a really crucial point. While initial rest is essential to calm things down, prolonged total inactivity can paradoxically lead to that disuse osteoporosis, which actually weakens the bone you're trying to heal. So the goal isn't just no activity, it's about removing the specific detrimental stress that caused the injury in the first place. For some cases, once the initial acute pain and inflammation subside, controlled, limited exercise, like hand walking on a firm, level surface, might actually be preferable to complete box rest if it doesn't cause any return of lameness. But this requires really careful ongoing veterinary assessment and potentially repeat imaging to guide that gradual reintroduction of activity. It's not a one-size-fits-all approach.
Right, got to tailor it to the horse and the injury. And what other supportive measures are part of that conservative management package?
Beyond managing activity levels, it's about providing a good environment, warm, dry, dust-free for comfort and respiratory health, palatable feed to keep their appetite up, judicious use of NSAIDs like phenylbutazone or flunixin for managing pain and any associated fever, especially in the early stages, and maybe warm compresses for localized inflammation once the acute phase is passed. Just general good nursing care.
Okay. Now, what about surgical intervention? When do vets consider that more invasive approach for a stress fracture?
Right, surgery is definitely not a routine first-line treatment for the typical stress fracture. It's generally reserved for very specific cases. For instance, certain distal limb fractures, like in the cannon bone or pastern, where the bone might need internal fixation, like screws, to stabilize it and prevent propagation to a complete fracture. Or, unfortunately, when an undiagnosed or poorly managed stress fracture progresses to a catastrophic complete fracture, that's an emergency situation. Surgery might also be considered for more severe or complex stress fractures, or if conservative management definitively fails to resolve the lameness and allow healing, which can sometimes happen with issues in the proximal phalanx, the long pastern bone.
Can you briefly describe what those procedures might involve? Sounds pretty major.
They often require general anesthesia, which carries its own risks, though some specific procedures might be done standing with heavy sedation and local blocks. For simpler fractures, it might involve placing one or more screws across the fracture line to compress and stabilize it, what we call lag screw fixation. More complex fractures could require multiple plates and screws applied to the bone surface to bridge the fracture and provide rigid support. Post-operative care is intensive, always involving strict stall confinement initially, often with casts or heavy bandages for support, and a course of antimicrobials to prevent infection and anti-inflammatories for pain and swelling.
And what are the outcomes like after surgery?
They really vary depending on the bone and the severity. For example, about half of proximal phalanx stress fracture cases treated surgically might return to athletic activity. However, and this is a very sobering fact we have to mention again, complete humeral fractures, even if surgically repaired, carry an almost universally high fatality rate in adult racehorses due to the difficulty in achieving stable fixation and managing complications.
That's truly sobering. It really underscores the importance of catching these early. It also raises that tough question. How do vets and owners balance the risks and costs of surgery against the potential for catastrophic failure if it's not pursued? Must be an incredibly difficult conversation.
It is every single time, which is why the diagnostic phase and careful monitoring during conservative management are so absolutely vital. But assuming a successful initial phase, whether conservative or surgical, let's talk about rehabilitation protocols. A phased return to activity. This is crucial, right? It's not just static rest and then suddenly back to full work.
Yeah, how does that work?
Absolutely not. It's crucial to understand this is a gradual, methodical, and dynamic process. The goal isn't just healing, it's also stimulating healthy bone remodeling and actively counteracting any disuse osteoporosis that might have occurred during the rest period. We need to build the strength back up slowly.
Can you outline a typical protocol, maybe using those pelvic or vertebral stress fractures as an example, since they often have a good prognosis?
Certainly. A typical approach might start with initial box rest for the acute lameness, maybe a few weeks. Once the horse is consistently sound at a walk, we gradually introduce controlled walking exercise, perhaps starting with 10-15 minutes twice daily, and slowly increasing over about 4 weeks. Then, if they remain sound, we progress to ridden trotting, again starting short and building up duration and intensity over perhaps an additional 2 to 4 lucks. Cantering can often begin after around 6 to 8 weeks total, depending on the case, starting with short bursts and then maybe alternating cantering days with ridden trotting days for faster work. The reintroduction of high-impact exercise like galloping or jumping is usually held off until around the 3-month mark, sometimes longer, and only proceeds if everything looks good clinically and potentially on follow-up imaging.
So it's a very slow step-by-step process.
Very slow. And regular veterinary reassessment at each stage is crucial. Close collaboration with a veterinary physiotherapist can also be incredibly helpful for guiding specific exercises and monitoring progress. Tibial stress fractures, for example, typically involve a similar controlled rehab period, often around 12 weeks or sometimes more, before a gradual return to faster work. Successful rehab truly requires individualization and flexibility based on how the horse responds.
That makes perfect sense. Beyond rest and structured rehab, let's discuss therapeutic shoeing, principles, and specific applications. How can specialized farriery actually play a role in helping a bone heal?
This is a really fascinating area where biomechanics and the farrier's craft come together effectively. This specialized shoeing literally alters the forces acting on the injured bone and surrounding structures. It uses precise biomechanical principles to create a more optimal healing environment.
Interesting. What are those core principles? How does it work?
Well, they primarily include things like redistributing the load. So, shifting the ground reaction force away from an injured area, maybe using a bar shoe, or trying to distribute the weight more evenly across the entire hoof capsule. Another key principle is repositioning breakover. This means adjusting where the hoof naturally pivots or pushes off the ground as the horse moves. By moving that point slightly back towards the heel, or palmarly plantarly, we can reduce the leverage forces that strain structures at the front of the leg and also decrease tension on key tendons like the deep digital flexor tendon, DDFT. And finally, providing heel elevation when necessary, using wedge pads or specialized shoes. This can also significantly decrease tension on the DDFT and change the loading pattern within the hoof.
Can you give us some specific examples of how these principles are applied in fracture cases?
Sure. For issues like navicular bone stress fractures or injuries, corrective trimming combined with shoeing that provides heel elevation. Maybe using 12-degree wedge pads can significantly improve comfort and potentially the prognosis. These would typically be reset every 4 weeks. For distal phalanx or coffin bone fractures, a common therapeutic option is a wooden shoe. It's often constructed from something simple like plywood for accessibility and rigidity. This wooden shoe helps to stabilize the entire hoof capsule, restricting movement at the fracture site, and it promotes healthy, even hoof wall growth as the horse recovers. The construction and application requires skill, of course, and this really highlights the crucial role of a skilled, knowledgeable farrier as an integral part of the veterinary team for a truly holistic approach to healing these injuries. It's not just about the vet.
That's a great example of that team effort. Okay, next, let's look at adjunctive therapies, things used alongside the primary management. What about extracorporeal shockwave therapy, or ESWT? What exactly does it do?
Right, ESWT uses high-energy acoustic or sound waves directed at the injury site. These waves create controlled microtrauma at the cellular level. This process is thought to stimulate the body's natural repair processes, increase local blood flow, enhance the production of growth factors and other healing factors, and it can directly stimulate new bone formation by osteoblasts. It also provides significant pain relief or analgesia. It's non-surgical, the treatments are relatively quick, usually done sedated, and generally has few reported side effects.
Okay, stimulates healing, relieves pain. Sounds good. But there's a big but here, isn't there? This therapy also comes with significant controversy, particularly when used for stress fractures. Can you explain that side of it?
You're absolutely right. The major concern, and it's a serious one, is that the potent pain-relieving effect of ESWT can lead to horses feeling sound and comfortable before their bone is actually structurally healed and strong enough to withstand training loads. This carries a really high risk of the horse being returned to work prematurely, which can then obviously exacerbate the original injury, delay healing further, or even cause to progress to a complete catastrophic fracture.
That's a huge risk.
It is. Determining when it's truly safe to return to work after ESWT becomes a major challenge if you're just relying on subjective lameness assessment, because the horse might look sound due to the analgesia. And adding to the complexity, some scientific reviews have indicated relatively weak evidence for its long-term benefits in certain bone conditions compared to just rest and rehab. Plus, sedation is often needed for the procedure itself. So the bottom line is clinicians must prioritize objective assessments of bone healing primarily through follow-up imaging like x-rays or maybe even another bone scan over just subjective improvement in lameness after ESWT. And it's crucial to thoroughly educate owners and trainers on the significant risk of returning to work too soon based only on how the horse feels.
So it's a tool, definitely, but one that needs very careful management and objective follow-up. What about other physical therapies that might be used during rehab?
Yeah, other modalities can be very helpful. We often incorporate manual therapy, which includes things like passive range of motion exercises, gentle stretching, and specific tissue or joint mobilization techniques. The goal here is to help maintain or restore normal joint movement, reduce pain from compensatory muscle soreness, and decrease stiffness that can develop during periods of stall rest or reduced activity. Thermal therapy is common too, using cold packs or ice boots initially for the first 24-48 hours after injury or strenuous rehab sessions to reduce swelling and pain. Then, later on, perhaps alternating cold with heat therapy to increase blood flow and tissue extensibility. Electrotherapy modalities like therapeutic ultrasound, different from diagnostic, or laser therapy are sometimes used. And hydrotherapy like underwater treadmills or swimming, once appropriate, can allow exercise with reduced weight bearing. All these therapies support the horse's overall comfort and can facilitate a smoother, more effective rehabilitation process.
Okay. And finally, in this section, nutritional support and bone healing supplements. How important is diet in the recovery process?
Optimal nutrition is absolutely foundational, not just for healing, but for prevention too. A well-balanced diet provides all the essential building blocks the body needs. That includes adequate energy and protein, plus key vitamins and minerals specifically important for bone health, things like calcium, phosphorus in the right ratio, magnesium, copper, zinc, manganese, and vitamins A, C, D, and K. All of these play critical roles in bone development, remodeling, and repair.
Right, the basics have to be covered. Are there specific supplements marketed for bone health that have shown promise?
Yes, there are quite a few products out there. Some commonly discussed ones include things like Platinum Performance Equine or their CJ formula, Ocean, which focuses on providing silicon, thought to be important for collagen cross-linking, and Pro Bono, which combines vitamin K, vitamin D, collagen peptides, calcium, and phosphorus. Products like Duraplex and Triactin from Kentucky Equine Research have actually shown some positive effects on bone density markers in controlled research studies on horses in training. However, it's really important to remember that while supplements can potentially help support bone health, perhaps counteract some demineralization during stall rest, or provide specific nutrients, a correctly balanced base diet is always primary for bone strength and healing. Supplements should be seen as supportive tools, not standalone cures or replacements for proper nutrition and management.
That's a great point. Supplements supplement, they don't replace the fundamentals. Okay, now let's address what you rightly called a profound ethical and clinical dilemma in equine sports medicine. The controversy surrounding bisphosphonates, or BPs, especially in the context of stress fractures and young performance horses. Can you explain what these drugs are and why they've become so contentious?
Right. Bisphosphonates, or BPs, are a class of drugs that are powerful anti-resorptive agents. Their primary mechanism is to inhibit the activity of osteoclasts, those cells we talked about that resorb or break down bone tissue. They do this mainly by binding directly to the bone mineral surface. When osteoclasts try to resorb bone that has BP bound to it, the drug interferes with their function and can even promote osteoclast cell death, basically shutting down bone breakdown in that area. They also seem to have some analgesic or pain-relieving and anti-inflammatory effects, though the exact mechanisms aren't fully understood. In horses, two non-nitrogenous BPs, Tildrin, toludronate, and Osphos, clodronate, are FDA approved, but importantly, they are primarily approved for controlling clinical signs associated with navicular syndrome, and specifically only in horses 4 years of age and older.
Okay, approved for navicular in older horses. So what are the core controversies and concerns that have emerged around their use, particularly when people might be using them off-label for things like stress fractures or in younger horses?
There are several major concerns, and they're quite significant, leading to restrictions by many racing jurisdictions. First, there's widespread concern about interference with normal bone healing and adaptation. Remember, bone remodeling, that balance of breakdown and buildup, is essential for repairing microdamage and adapting to training stress. BPs potently inhibit the breakdown part, which could actually impede or significantly delay the healing process of a stress fracture.
So it stops the cleanup crew, essentially.
In a way, yes, or slows them way down. Second, related to that, some fear an increased fracture risk long-term. By inhibiting normal bone turnover and potentially increasing the amount of older, more mineralized bone, BPs might increase bone stiffness, but also brittleness. This could theoretically lead to the propagation of existing microcracks or the development of new ones, potentially increasing the risk of catastrophic fractures during high-intensity exercise, although proving this definitively is complex. A huge area of concern is extra-label use in young horses. Despite the FDA recommendation against use in horses under 4 years old, there have been persistent anecdotal reports and some evidence of them being used off-label in 2- and 3-year-olds, perhaps to manage soreness or prevent issues like bucked shins.
Why is use in young horses such a worry?
It's particularly worrying because osteoclasts are naturally very abundant and active in the growth plates and developing bones of young growing horses. There's a real concern that BPs could impair normal physiological bone development and maturation. There have been reports of erratic or delayed bone healing observed in young horses that were given BPs. Another significant concern is the masking of pain. The analgesic effect of BPs can make a horse seem sounder than it really is, masking underlying bone pain from a stress fracture or other injury. This can easily lead to horses being pushed back into work when their bones aren't adequately healed, putting them at severe risk of making the injury much worse or suffering a catastrophic failure.
Right, similar issue to the shockwave therapy analgesia, but maybe more prolonged.
Potentially, yes, because BPs have a very long residence time in the body. They accumulate significantly in bone tissue and are then slowly released back into circulation for months or even years after administration. And crucially, there's no known pharmaceutical way to reverse their effects once they're in the system.
Wow, months or years.
Exactly. And finally, there's a significant lack of robust scientific data. There's a critical gap in our understanding of the full biological impacts of BP use in young exercising animals, particularly those under 2 years old. And there's a real lack of high-quality, independent scientific data, specifically evaluating their effectiveness and safety for stress fracture management in racehorses. Much of the use has been based on extrapolation or anecdotal reports.
It's a lot to consider. It really does sound like their use requires extreme caution, weighing a potential risks versus the intended benefits very, very carefully, especially given the long-term presence and lack of reversal.
Absolutely. Objective diagnostic assessments of the underlying condition and strict adherence to regulatory guidelines and withdrawal times are paramount if they are used. And honestly, more robust independent scientific research is desperately needed to fully understand their long-term effects and appropriate clinical applications, if any, in young performance horses.
Okay, a complex and controversial topic for sure. Let's shift our focus now towards the end game, the outcome and prevention. Looking ahead. Starting with the prognosis and long-term outlook for horses that do get stress fractures. If a horse gets one and it's managed properly, what's the general prognosis?
Encouragingly, the general prognosis for most equine stress fractures is actually quite favorable and often good, especially if they are diagnosed early and managed appropriately with timely intervention, usually meaning rest and controlled rehabilitation. Most of these injuries heal without significant complications once the excessive mechanical stress is removed. And cortical bone typically restores its biomechanical properties over time, although full remodeling takes months. There's also a relatively low recurrence rate reported for many types of stress fractures once horses successfully return to racing or performance.
That's definitely reassuring to hear. What factors really influence that generally good prognosis? What makes the difference?
Several key factors play a role. The severity of the initial bone damage is important. Is it just mild remodeling or a distinct fracture line? The horse's age can influence things while any age can be affected. That 1 to 5 year range is often where we see the most severe clinical signs, and the 2 to 4 year olds are the most commonly diagnosed group. But critically, the most important factors for a good outcome are early detection and appropriate management, getting that diagnosis quickly, and starting the right plan, followed by strict adherence to a controlled and progressive rehabilitation program. As we discussed, that careful, gradual return to exercise is key. Effective intervention during that critical window we talked about, before minor damage progresses, truly helps prevent progression to more severe, potentially complete fractures.
Okay, so early diagnosis and sticking to the rehab plan are paramount. Does the specific location of the fracture matter much for the prognosis? Is, say, a pelvic fracture different outcome-wise than a tibial one?
Yes, the site-specific prognosis is quite important and does vary. Tibial stress fractures, pelvic stress fractures, and vertebral stress fractures generally carry an excellent prognosis for a full return to previous performance, including racing. The vast majority manage to get back successfully. Humeral stress fractures in the upper forelimb also typically allow a return to racing, although the recurrence rate might be slightly higher, maybe around 15% in some studies. However, and it's vital to emphasize this stark contrast again, complete humeral fractures, if a stress fracture progresses all the way through the bone, are almost universally fatal in adult racehorses due to the challenges of repair and catastrophic failure. So, yes, prognostic discussions with owners should always be tailored to the specific location and the severity, whether it's truly just a stress fracture or if it has unfortunately progressed.
That distinction between an incomplete stress fracture and a complete fracture is just so incredibly critical, especially for certain locations like the humerus. What about long-term outcomes and recurrence prevention? Are there hidden dangers or subtle long-term implications, even if a horse seems to recover well from a diagnosed stress fracture?
Long-term outcomes are generally positive, as I mentioned, with relatively low recurrence rates reported for many types if managed well. However, here's the significant finding that comes from post-mortem studies on racehorses that maybe didn't have a specific diagnosis during life. Evidence of subtle, healed, or healing previously undiagnosed fractures was found quite commonly. For example, in 28% of pelvises and remarkably 50% of vertebrae examined in some studies. These often likely presented with those vague signs we talked about, maybe just poor movement, stiffness, or reduced performance rather than overt, easily blockable lameness.
Wow. So half the horses might have had vertebral changes suggesting past stress injury.
In that particular study population, yes. What's fascinating and a bit concerning here is that this suggests these often undiagnosed injuries can be a significant and frequently silent cause of suboptimal performance. They might be limiting a horse's athletic potential over time without anyone realizing exactly why the horse isn't performing at its peak. It really underscores again why advanced diagnostics like bone scans can be so crucial, not just for acute lameness, but maybe for investigating those horses with chronic, low-grade performance issues. They might pick up these otherwise hidden problems.
That's a powerful point about those silent injuries potentially holding horses back. It really changes how you might look at a horse that just seems consistently off its best form. Finally, then, let's talk about the most vital topic, prevention of equine stress fractures. What's the best way to proactively condition bone and try to keep these injuries from happening in the first place?
Prevention is truly a multi-pronged approach, and it's all focused on proactively conditioning the bone to withstand the stresses of training and competition. It's about building resilience. First and foremost are optimized training regimens and workload progression. This means gradual, sensible workload increases are absolutely non-negotiable. Avoid sudden big jumps in intensity or duration. For example, studies caution against rapidly increasing gallop or canter distances, like going over 6 kilometers per workout at gallop, or accumulating more than 44 kilometers of canter work within a 30-day period, especially in young or previously unfit horses. It might actually be beneficial sometimes to reduce the volume of low-speed work and instead increase the frequency of short-interval, higher-speed work, as this seems to be a more potent stimulus for the necessary bone adaptations. Also, incorporating cross-training on varied surfaces, maybe some work in an arena, some road work, some grass gallops, helps strengthen not just bones, but also ligaments and tendons in different ways. And of course, individualized programs are key. Consider the horse's age, history, and discipline.
So smarter training, not just harder training.
Exactly. Second are nutritional strategies for skeletal health. As we touched on for healing, a well-balanced diet is fundamental for prevention too, ensuring adequate intake of energy, protein, and all those necessary vitamins and minerals, omega-3 fatty acids for anti-inflammatory effects, antioxidants, possibly silicon, and definitely calcium, phosphorus, magnesium, copper, zinc, manganese, and vitamins A, C, D, and K. Good nutrition helps provide the building blocks for strong bone and can also help counteract any demineralization that might occur due to periods of increased stall confinement during training.
Makes sense. What about surfaces?
Right. Third is considering the impact of training and racing surfaces. As we discussed, surface properties directly interact with biomechanical forces. We know things like deep sand gallops can increase the risk of certain fractures, and dirt racing historically has higher injury rates than turf. While we can't always choose the competition surface, exposing young horses to a variety of different surfaces during their early training and incorporating controlled, low-grade concussive exercise from an early age helps bone to adapt and strengthen appropriately for the higher loads to come.
So variety is good for adaptation.
Yes. And finally, don't overlook general management and biosecurity practices. Optimizing the horse's living environment and social interactions can play a role. Things like maintaining stable field groups if possible, ensuring consistent daily routines, these can help reduce stress-related behaviors, like stall walking or weaving, which could potentially cause repetitive trauma or lead to a predisposition for injury. Good biosecurity also prevents diseases that could weaken the horse. Ultimately, prevention is truly a holistic approach. It requires deep understanding and collaboration among veterinarians, trainers, owners, and farriers, all working together to manage the horse proactively.
This deep dive has really given us, and hopefully you listening, a comprehensive understanding of equine stress fractures. From the incredible dynamic nature of bone itself, always remodeling, to the often subtle and elusive signs of injury. The sophisticated array of diagnostic tools vets now have at their disposal, the nuanced treatment strategies balancing rest and rehab, and ultimately the critical importance of that proactive, multi-pronged approach to prevention.
It really is a complex picture. Maybe a final thought for you listening. What stands out to you about this delicate balance we've discussed? The balance between pushing an equine athlete to its absolute peak performance and simultaneously protecting the very foundation, the skeleton, that allows that performance. It's a constant tightrope walk.
That's a great question to ponder. We encourage you to reflect on these insights, perhaps observe athletes, whether they're human or animal, with maybe a new appreciation for the incredible biomechanics involved and the hidden stresses they endure. And if you found this deep dive valuable, please share it with anyone you know who's interested in equine health, sports medicine, or the science of peak performance.